So what's the cost of violence then to you, our healthcare organizations, and of course our patients? So some of you may have seen this iceberg model before, but if you're not familiar with it, and if you're a staff nurse listening to this webinar, you might say, well, why do I need to know this? You know, I need to know why workplace violence impacts me and my patients, but why is it important to know how it impacts the healthcare organization? Well, the answer is it's all interrelated, and we want nurses to speak up and be part of workplace violence prevention efforts. So you can inform your committees, you can inform your co-workers and your employers about the resources out there to develop successful programs and the context for this whole topic. So at the top of the iceberg, we have our medical costs. When you're injured on the job, there's time away from work or modified duty. There's a cost associated with that. And then your workers' compensation costs. And we call those the direct costs. Our indirect costs are when we have to replace a nurse or a CNA who is on modified duty or is away from work due to injury. So that replacement costs. And those costs together can be considerable. But one of the problems that we have with workplace violence is underreporting. So if we're just going to rely on our injury data, and this comes from what we call the OSHA 300 log. This is what employers in the US, 90% of employers have to complete and track work-related injuries on. If we rely on that data on our code grey reports, we're not really going to get a full scope of the issue, and we're not going to be able to design an effective workplace violence prevention program. So we have to look under the iceberg here and look at the indirect impact of violence on our patients and the healthcare organization overall. I'm going to talk about the impact on staff in a second. So we know from the literature, this has been fairly well researched in the last 8 to 10 years, that there's a huge component of psychological stress, post-traumatic stress disorder, burnout, and presenteeism when you're exposed to violence. And presenteeism, if you're not sure heard of that term before, is when we're working in physical or psychological pain and we cannot perform our job 100% of how we want to perform it and provide the best care for our patients. When it comes to bullying or type 3 violence, this is strongly associated with post-traumatic stress disorder. But overall, any exposure to violence, we can see that you're going to have more sick time away from work when we compare to employees who are not exposed to violence. And certainly we see it linked to burnout and higher rates of turnover. Ultimately, this is going to, impact our quality of care or service to our patients. If we look at the research overall, we know that as the workload increases for our nurses, there's more fatigue and error, and the likelihood of patient death increases significantly. I think we're really in those early stages of finding out the big impact of violence for our patients and healthcare organizations. Some of the other factors we have to think about, though, are insurance costs, property damage due to violence, litigation, security needs, hiring more security personnel, security surveillance systems, panic alarms. These all come with a cost associated with them. And then if you don't comply with regulations such as the Joint Commission Violence Standard, then what is that cost going to be? Now, if we overlay the pandemic on top of this, all of this is exacerbated. All of this impact is exacerbated. And the ECRI, which is a Quality and Safety Research Institute, they put out a top 10 list of hazards that are threats to patient safety every year. And the number one threat to patient safety this year is the shortage of staff, which is no surprise to any of us. We've seen more stress, fatigue, post-traumatic stress disorder because of COVID, as I mentioned earlier. And unfortunately, suicide rates amongst nurses and doctors have increased significantly. They were already greater than the general population prior to COVID. They're now greater because of COVID. A couple of other statistics to drive this point home. The Association of Critical Care Nurses back in June reported that 66% of their members considered leaving their employment this year. And then in 2020, the nurse turnover rate is estimated to be about 18%. So these numbers are staggering, and turnover of staff directly impacts patient safety. And we're just starting to see the impact of COVID and the lack of staff and all the stress we've been through on patient safety, particularly when we're talking about hospital-acquired pressure injuries and falls. Now, what about staff? We know that the cost of work violence to staff can result in death. and I want to tell you about Lynn Truxillo. Some of you may have heard of her. She was a 56-year-old general nurse in Baton Rouge, Louisiana. She tried to save her colleague from attack by a patient. The patient first attacked another nurse in the hospital's behavioral health unit. He charged towards the nurse and pinned her to a corner as he kept swinging his arms at her and tried to grab her. Lynn stepped in and was able to pull the patient off the nurse, but she tried to flee and the patient grabbed her by the back of the neck and violently pushed her head down, striking her head on the desk. Lynn tried to pull away and injured her right leg in the process. Lynn died a few days later as a consequence from multiple pulmonary emboli that had resulted from her injuries. Since then, this patient has been charged with manslaughter, and I don't have the latest on that case, but charges were brought against that patient. The new workplace violence law that took effect in August this year in Louisiana is named the Lynn Truxillo Act. Although this is rare, it does happen. And unfortunately, we're seeing that increase in violence in our healthcare environment since COVID. We also have to think about the physical injury and disability, the psychological stress, the post-traumatic stress disorder. And then bullying has been very well researched and is strongly associated with poorer mental health, lower self-esteem, and then physical symptoms and a decrease in cognitive abilities, which leads to impaired clinical judgment. And interestingly, bullying, because of this impact, is associated with more errors by nurses because of PTSD. Now, when nurses were asked, why do you think bullying is far more traumatic than a patient assault and physical injury, nurses responded with, well, the patient didn't mean to hurt me, but my coworker knows exactly what they're doing. It's intentional. Quite surprising, right? So something to think about. I'm not going to read this slide. This is just a guide for you. We're still researching what the cost of violence is to healthcare organizations, whether it's patient violence or bullying, incivility, in the dollar form. But you can see it's staggering. It's billions of dollars. And this data came before it was calculated prior to COVID. I'm going to probably take an intelligent guess that this has increased significantly. The one thing to ask, though, and to ask your employers is how much reimbursement are they going to have to make, or how much money are they going to have to make to offset the cost of these injuries due to violence? And when I've calculated that for employers, and especially when you add in musculoskeletal disorders and slips, trips, and falls, they have to make millions more a year to offset the cost of these injuries. It's not a great way to run a business. So it's another way to look at this.